Hello, everybody. Thank you for joining this webinar today. We're going to be talking about bowel ultrasound, which would mostly entail an ultrasound case series evaluating the appendix and the bowel. I have nothing to declare. However, I love ultrasound. Therefore, I'm going to be a bit biased towards ultrasound today. But yes, aside from my love for ultrasound, I have nothing to declare. Here are my credentials. My name is Emmanuel Abiola Babinton. I'm an adult and pediatric sonographer at the University Hospital of Leicester in Leicester, UK. And I have an MSc in medical ultrasound. I have special interest in bowel ultrasound, and I practice that on a daily basis here in Leicester. Here are the learning objectives. At the end of this lecture, participants are expected to understand the perils and pitfalls of bowel ultrasound. We're also going to discuss a lot about the bowel anatomy. We are also going to discuss about bowel ultrasound scanning techniques, tips and tricks, the ultrasound appearance of the normal appendix, the ultrasound appearance of uncomplicated appendicitis, as well as complicated appendicitis. And we'll discuss about inflammatory bowel diseases, which includes Crohn's disease and ulcerative colitis. So let's begin. Ultrasound in the past has always had this myth among sonographers that, it can't examine the bowel, so ultrasound cannot examine the bowel. I carried out some research sometime last year among sonographers regarding their interest in bowel ultrasound, and it was interesting to find that a number of sonographers still believe the ultrasound cannot examine the bowel due to bowel gas. And we still carry on that mindset. I want to hope that we are all here today because we believe ultrasound can actually examine the bowel. And hopefully by the end of today's presentation, we would all be able to know how to use ultrasound to examine the bowel properly. So we can agree that it's a myth that ultrasound cannot examine the bowel, because it can, with the right equipment and the right technique, and also above all, the appropriate training. The sensitivity of ultrasound in examining the bowel, based on numerous researches, range from about 75 to up to 98%, which is really good and impressive if you ask me. While the specificity also ranges from about 75 to 100%. Now this is highly dependent on the region that we're examining and also the nature of the pathology. For instance, if you're looking out for appendicitis, you tend to have a slightly different sensitivity and specificity compared to checking for erectile Crohn's, for instance. Also, the technique in which we adopt changes, improves the sensitivity and specificity by a lot as well. Now, these techniques would include transabdominal ultrasound, which is what we're going to be talking, which is what we're basing this presentation on today. Also, the endorectal ultrasound, endovaginal ultrasound to examine the rectum and the perianal region, the perineal ultrasound, the endoscopic ultrasound, which mostly examines the upper GI tract, contrast enhanced ultrasound, which is very useful in detecting slow flows, especially in cases of Crohn's disease, when we're checking for fibrosis of the for fibrostenosis, and also trying to differentiate between fibrostenotic occlusion and inflammatory stenosis. So contrast enhanced ultrasound is quite useful in that technique. And also shear wave elastography has also been proven to be very useful to increase the sensitivity and specificity of diagnosis of bowel-related pathologies. However, for the purpose of today's lecture, we'll be talking on transabdominal bowel ultrasound. So what are the perils of bowel ultrasound? Ultrasound is a very useful imaging tool in examining the bowel, which we are going to see today. Its real-time feature helps in observing peristalsis, and also we can perform sonopalpation, which is where we all do that, I believe, which is where we use the transducer. You ask the patient where the concern is, and then we use the transducer to check for response to pain, and that gives us an idea of what area the patient feels the most pain or tenderness. Ultrasound is also widely available. It's compared to its counterparts, ultrasound is quite cheaper. Ultrasound is non-invasive, it's particularly transabdominal ultrasound, and it can be performed usually without preparation. So in a case where, in an acute case, in an emergency setting where a patient, turns up with significant abdominal pain, the doctors are trying to figure out what's going on, you can instantly send the patient down to ultrasound to have them examined without any prior preparation. When done properly, ultrasound can prevent an unnecessary CT. However, we also need to know the limitations of ultrasound, and we should be more than ready to request further examinations when we know it's going to help our patients much more. Ultrasound provides more detailed information of the bowel wall than CT. And we all know CT uses ionizing radiation. MRI, patients who are claustrophobic might find it difficult to carry out an MRI examination. And also this CT and MRI are much more expensive than ultrasound. You need more operators and more specialists around in order to carry out the examination and report the images in cases of CT and MRI. In which ultrasound, once you have one well-trained specialist, sonographer, radiologist, or gastroenterologist, they can carry the ultrasound right there and then and get the diagnosis, while even showing the patient what's going on, and it gives patients more understanding of the situation and the disease condition. Lastly here, contrast-enhanced ultrasound is very useful for the visualization of wall vascularity, which is a very useful tool in the follow-ups of inflammatory bowel disease. Now, the pitfalls of ultrasound: the small bowel cannot be imaged continuously in its entirety. That, due to the anatomy of the small bowel, we can't follow it all the way through. Ultrasound is very operator dependent. As a sonographer, a radiologist, a specialist, a doctor, you need to really know what you're doing. You need to have a lot of training to be able to do bowel ultrasound. You need to, it's very dependent on what you do and on what you know. Ultrasound can also be very difficult when scanning the bowel in obese patients. It's not impossible. We have scanned a lot of patients that are a bit on the big side. We check with detected bowel lesions and things like that. We are bowel pathologists, despite the fact that they're obese. However, it's more tricky. But with the newer equipment these days, you have a range of transducer frequencies. You can use that to your own advantage when you know what you're doing. And also, when patients have significant tenderness, it tends to be a bit of a limiting factor, because you might need to apply graded compression. And with a patient who is seriously in pain, you might, that would most likely hinder you as a sonographer from doing so. You need a very good equipment. You need very good image quality. An equipment that gives you good image quality. You need multi-frequency transducers we need to have at least a curvilinear and a linear transducer to be able to carry out dynamic and complete bowel ultrasound, transabdominal bowel ultrasound examination. And also, ultrasound is difficult to access the bowel structure in the pelvis transabdominally. However, with the use of endorectal ultrasound, you can easily see very beautiful images of the rectum, the walls of the rectum, which is lodged in the pelvis. Sometimes the full bladder, transabdominally, you can image the rectum as well. And then using perineal techniques, you can also image the in cases where a patient has perianal fistula or perianal Crohn's disease, something like that. You can use the perineal technique to image that region. But in general, ultrasound it's quite tricky to access bowel structures in the pelvis. So, and also you can carry out transvaginal ultrasound. You can detect bowel lesions using transvaginal ultrasound. Now, the anatomy of the bowel. We all know the alimentary canal, the digestive tract, which starts from the mouth, the food. This is the canal where the food passes through from the mouth, obviously through into the esophagus, down to the stomach. Digestion starts taking place. Digestion starts taking place in the mouth, actually, from the salivary juice produced by the salivary glands. And then it continues in the stomach and small intestines, large intestine, and the waste comes out as a feces from the anus. That's the alimentary canal. However, when it comes to the bowel, the transabdominal bowel ultrasound, we would most likely be focusing more on the stomach, from the stomach down to the rectum. The stomach, as we know, has three parts: the fundus, the body, and the pylorus. We also have the duodenum, which continues from the pylorus as the first part, and then you have the second part, and then the third part. Then that continues as the jejunum. The jejunum is more visual, more identifiable on ultrasound because it has increased number of valvular connivences in comparison to the ileum. So you tend to recognize the jejunum because you can see more valvular connivences. It's a very distinctive feature in recognizing jejunum on ultrasound. Now the ileum, so the jejunum continues as the ileum. Then you have the distal ileum that ends at the terminal ileum. The terminal ileum is a very key aspect of bowel ultrasound because it's a very common location for Crohn's disease. So the terminal ileum ends at the ileocecal valve, and then it continues into the cecal pouch or the cecum. And below the cecum is where the appendix hangs. So that region where you have the terminal ileum, cecum, and appendix is usually in the right iliac fossa, around a point where it's mostly described as a McBurney's point. That's where we tend to use as a landmark to find the appendix in most cases. Then the colon continues from the cecum as the ascending colon, transverse colon, descending colon, and then sigmoid colon, and then the rectum and the anus. So here's an image, or a beautiful image actually, of the digestive system. So we can see up here the mouth with all the digestive glands, the salivary glands, and then the esophagus, and down to about here, that's where the stomach starts. So here's the stomach. You can see the greater curvature of the stomach and the lesser curvature of the stomach. You can see the fundus of the stomach there, and the stomach, in the wall of the stomach tends to have increased rugae. So you tend to have rugae within the wall. And then this ends as the pyloric antrum, and then the pylorus, which then continues here as the first part of the duodenum, second part of the duodenum, third part of the duodenum, and then you start the jejunum from about there. So you have mostly the jejunum, then the ileum. So you can see why we can't image the small intestine in its entirety, because it's all very, interwoven in a way. That's how God has created. But the bowel ultrasound still does a really good job at examining the small bowel. So the jejunum continues as the ileum, which then continues as the distal ileum, and then the terminal ileum, and then the ileocecal valve is in here, and then you have the cecum or the cecal pouch that's here, and you have the appendix hanging down there. And the cecum then continues up as the ascending colon, and you have the hepatic flexure of the colon there, and then you have the transverse colon here, and then the splenic flexure there, and the descending colon, and then the sigmoid colon, and the rectum, and then the anus. So that's a brief but detailed description of the bowel, the small bowel. So on ultrasound, the normal bowel would normally peristalsis. It tends to see peristalsis. Remember, ultrasound gives us real-time views of the bowel. So you tend to normal bowel tend to show peristalsis. It tends to be compressible, and you'd have the normal gut signature, which is also called the wall stratification or the wall layering. Now, what is the normal wall stratification of the bowel on ultrasound? There are 5 concentric hypoechoic layers of the bowel wall on ultrasound. And these layers then are named the hypoechoic serosa, the hypoechoic muscularis propria, the hypoechoic submucosa, hypoechoic mucosa, and then the hypoechoic superficial mucosa interface. The wall thickness of the bowel is varies along its path. So if we just go back here, so the stomach wall tends to measure up to about 6 millimeters. That's due to the rugae. The stomach has slightly thickened wall, even when it's normal. The small bowel, we tend to use about up to 4 millimeters as the upper limit of the bowel wall thickness, and then the large bowel up to 5 millimeters. Bowel wall thickness is a very important landmark parameter in examining the bowel. A bowel with an abnormal wall thickness would most likely be abnormal. Once you see an abnormal wall thickness, you need to look around for other features that would support that diagnosis. Other features like color, the color Doppler. You check the color, interrogate for hypervascularity, check for free fluid and things like that. We're going to get there. So continuation of the normal bowel. A common feature of the small bowel is the presence of valvulae connivensis. These are more seen in the upper jejunum than the distal ileum, as mentioned before. They are sometimes more obvious when the bowel lumen is fluid filled. Also, in cases when you have a small bowel obstruction, you tend to have distended bowel proximal to the point of obstruction. Therefore, you see the valvular connivency just hanging down from the wall of the bowel. They tend to be much more prominent when the lumen is fluid filled. But the large bowel don't have valvular connivency. They have obstructions, and this is very characteristic of the large bowel. And they are usually seen on ultrasound as echogenic gas pockets along the tract of the large bowel. So usually when the large intestine is normal, you tend to see this. So this is this image is taken from a 26-year-old female patient. It's a normal appearance of the large bowel. So that's the transverse colon. You can see the obstruction. The obstruction there. This echogenic gas pocket here. This echogenic area, the gas that hangs at the anterior wall of the large bowel, and it prevents you from seeing the rest of it. But that's absolutely normal. This is the same patient, descending colon of the same patient. That's on the right side of this image. So that's the ostration, and then you can see the gas pockets there in the anterior wall of the bowel. So here we have a 29-year-old female patient with normal appearance of the duodenum and the jejunum. So this is the distal stomach slash pyloric antrum. That then leads towards the first part of the duodenum. So we can see, you can see the wall of the distal part of the stomach slash pylorus there, and then also the duodenum there. And you can see much. You can see the left lobe of the liver here, and also the pancreatic head here. So this image was taken right in the epigastrium, just there. And we can see the normal duodenum. You can see gas pockets, this gas flowing to the anterior wall of the stomach and pylorus there. And on the right side of this image, you can see of the screen, you can see the jejunum with more prominent valvulae connivensis. Like I said, they're usually much more appreciated when the lumen of the bowel is ended. This lumen is completely collapsed. So usually within the prepared bowel, we tend to have empty lumens, and that helps you better to see. As I must mention that in preparation for an ideal bowel ultrasound, you're better off having a patient who's been fasting for at least 4 hours. That helps to empty out the bowel lumen and makes it and reduce bowel gas and bowel gas shadowing, and hopefully that helps with visibility more. And when you can't see things clearly, you can use the most natural oral contrast in the world, and that's water. You can give your patient lots of water to drink while in the examination room, and then you see how the fluid passes through the lumen of the bowel, and that helps you identify the wall stratification and other things. Now we come to scanning technique. So it is recommended to scan the entire abdomen and pelvis. In my hospital where I work, my trust, we always scan the abdomen and pelvis, check for all other possible cause of the patient, especially when it's a first time acute case, patient with right celiac fossa pain or left celiac fossa pain, square appendicitis, square diverticulitis, or things like that. We have to scan everywhere first, make sure we've ruled out ovarian cysts, rule out gallbladder problems like gallstones, rule out all other possible causes of pain in the abdomen before we then focus on the bowel. So when you're done scanning the abdominal organs, then it's advisable to look to continue using your curvilinear probe. The probe we use is a multi-frequency probe, so it goes up to about 6 to 6.5 megahertz for curvilinear. So you can increase your frequency to about that. If it goes up to 4 or 5 megahertz, that's still fine. So you increase your frequency, but reduce your depth in such a way that you bring everything closer to your screen. So you then interrogate the bowel. So just have a good look at the entire bowel by mowing the lawn, just like that. Just follow it that way. Or you come from reverse, so from the sigmoid colon. I normally start from the sigmoid colon and just mow the lawn backwards that way. And just do that and just go slowly. Check for any abnormal bowel wall thickness, any area of hypo or peristalsis, any lump, mass, bowel dilatation, luminal dilatation, narrowing, and things like that. So sweep using curvilinear, then switch to a linear transducer, which is between 5 and I'd normally just use 9 megahertz, but to be precise, I always use 9 megahertz linear transducer. So you do exactly the same thing, and when you find an area of bowel wall thickening or any suspicion of abnormality in the bowel, after scanning everywhere, you come back and focus on that. You try to interrogate that transversely and longitudinally. Try to identify what part of the bowel, the anatomy now. Identify what part of the anatomy that is. If you find an evidence of small bowel obstruction dilatation, it's always important to find the cause of that obstruction. So follow that dilated bowel loop to the point where it's no longer dilated. And usually around there, you'd find the cause of obstruction that could be caused by a lot of things. And while scanning, remember to apply graded compression. You can use this technique to the top right corner of the screen here. Apply a bit of pressure on the patient's back and just press slowly but firmly while scanning. So that technique helps to eradicate bowel gas, and it helps to bring the bowel closer to the transducer, which in turn gives you more higher quality imaging feedback, which would help with diagnosis. So apply graded compression, and when you're in the epigastrium here, you tend to see the stomach, the pylorus, and usually the duodenum, which is what I showed you here. So that's the epigastric region, the epigastrium. You see more of the stomach, the pylorus, and the first part of the duodenum. And if you come down a bit, you can then see the jejunum, like the transverse colon. So yeah, then you can follow the stomach and the pylorus, the duodenum, and then the jejunum, the ileum, and you can just follow that all through like that. So you get to the terminal ileum, which is around where this transducer is. The terminal ileum, and then from there you'd get to so from the terminal, it's always very important to identify a normal terminal ileum. I'll show you a lot of images of terminal ileum today. So once you identify that, and then the cecum will just be next to it, to the right, to the patient's right, and just around there, ileocecal region, you find the appendix hanging somewhere there. So it's always important, after you've checked everywhere, then come around and take your time in the right side to be able to visualize those important bowel ultrasound landmarks, which are the terminal ileum, the cecum, and the appendix. So for more scanning technique, the cecum can be imaged in the terminal ileum in the right iliac fossa, as mentioned earlier. If you look at the image on this side here, you can see that in some cases you turn your patient on the left lateral decubitus position. That would help move the unwanted small bowel around, it moves it away, out of the way, and then it brings out the appendix and the cecum. So it makes it easier to image. Sometimes that works, and if it doesn't, put your patient back on the supine position and continue as you've seen here. So the appendix is usually in close proximity to the cecum and the terminal ileum. The rest of the colon can be imaged by following its anatomical course, which is, I'd normally do it in reverse, to be honest. I'd normally come from the sigmoid colon around here, and then just follow that up to the descending colon. So over here, you find the bladder. If your patient has a full bladder, you might be able to see a bit of the rectum. But in most cases of when we scan the bowel using transabdominal technique, we don't tend to see much of the rectum, but the sigmoid colon tends to be diagnostic. Visualizing the sigmoid colon properly tends to be diagnostic enough, especially when we are ruling out ulcerative colitis. So sigmoid colon, and I follow the descending colon up to the splenic flexure, and then you then follow the transverse colon, which I showed you earlier. So the transverse colon all the way down to the hepatic flexure, and then follow the ascending colon, but in reverse now. So ascending colon downwards, and then you get to the cecum. And when you do that, you know you are in conjunction with scanning more in the lung to check the small bowel. You know you've covered a lot of the bowel. You can be rest assured that you most likely, if you've done that slowly and correctly, you most likely haven't missed any bowel pathologies. So the rest of the colon can be imaged by following its anatomical course as the ascending, transverse, descending, and sigmoid colon. But like I said, I do it in reverse, so sigmoid, descending, transverse, and ascending colon. And quite a lot of literature that I have encountered, and some textbooks as well, and even conferences where renowned gastroenterologists who have written lots of books on bowel ultrasound delivered lectures. They expressed the consensus that they also scan the bowel in reverse from the sigmoid colon. They find it easier and more organized to do so. So it's kind of from the sigmoid colon all the way back. And that's partly because you're sitting on the right side of the patient here. So you want to get the distal most part, the part that is away from you first, and then you can follow that course like that slowly until it comes closer to you. So that way you're working your shoulder less, and it's you don't lose muscle tone when you get to the other end. Meanwhile, instead you're coming closer to you, so it's easier and you're able to focus more on the scanning. So we should use color and power Doppler when we find abnormalities to interrogate structure. The normal bowel don't tend to really give much color signal. However, when there's an inflammation, you tend to find increased color signal. You tend to find bowel thickening. In many cases, you also find mesenteric fat edema around it. So the bowel is a bit calm around that area. There will be no peristalsis or reduced peristalsis. You might find a bit of free fluid. You might find luminal dilatation or narrowing. You might find like collection and abscess. And then, like I said earlier, mesenteric edema. So those are the signs that you've reached a place where there is a possibility of bowel abnormalities. So when you're there, you need to be more focused, you need to take your time more. So the appendix is a blind-ended tubular bowel structure. It arises from the cecum. So in the images here, we can find the cecum there. So this is a close-up image, zoom image on the right iliac fossa. So you can see the terminal ileum there, distal and terminal ileum. Terminal ileum goes into the ileocecal, continues ileocecal valve into the cecum or the cecal pouch, and then you find the appendix hanging down there. So this area here, you can see the appendicular artery, and you have the mesenteric fat. So when the appendix gets inflamed, the fat gets edematous. So the appendix can either be anticecal, cecum appendix anticecal, or retrocecal in orientation. And the position of the appendix can vary due to its orientation, anti or retro, or sometimes the cecum itself can be low-lying or lie upwards. You can have the cecum hanging a bit higher, so you have that. So that makes the appendix a bit higher, and in some cases the cecum comes all the way down, and the appendix is well into the pelvis. And some appendix are just longer than the rest. Some literature that I've encountered gives us the length of an appendix to be between 8 and 20 centimeters long. So it varies. But in most cases, you find it in the right iliac fossa. So frequently you can see the medial, and you can see the appendix medial and caudal to the psoas, iliopsoas muscle, which I'll show you on more images. And they obviously vary in length and sometimes extend into the pelvis. So on ultrasound, the normal appendix appears to be blind-ending, tubular, non-peristalsing, but compressible loop of bowel when it's normal. Its wall has 5 layers, just like the other bowel structures. Remember the 5 layers of the bowel: hyper, hypo, hyperechogenic. So hyper, serous layer, muscularis propria, subserosa, muscularis propria, submucosa, mucosa, and the mucosal interface. Those are the 5 layers of the bowel, and it's exactly the same in the appendix. The appendix measures up to 6 millimeters when it's normal in AP caliber. That's a combination of the entire anterior posterior caliber of the appendix. So the wall tends to be around 2.5 to 3 millimeters when it's normal. So it's less than or equal to 6 millimeters in total at AP caliber when it's normal. The lumen of the appendix of a normal appendix can contain some air. In some cases, you might find some fluid in the lumen, even though it's normal. You can find fecal material, or you can find calcification, which is called appendicolis. So even a normal appendix can have appendicolis in it. So we'll look at some cases where we found the normal appendix, and I'll show you some images that accompanied that were acquired during those examinations. So this case one, the first case is a case of a 6-year-old female who presented with 3-day history of right-sided pain, fever, and vomiting. C-reactive protein was 107, which is a lot, and the white cell count was 12.7. I think the landmark we use in our trust is 10. So any CRP above 10 and WBC above 10, then it's abnormal, and that gives an insight and a suggestion of inflammation going on. So ultrasound on this patient revealed a 4 millimeter normal appendix in the right iliac fossa, and due to the continuous spike in temperature and the clinical suspicion of appendix perforation, the clinicians were thinking this patient has a perforated appendix, because even after having the ultrasound, they still felt like, oh no, the appendix can't be normal. She must have some kind of appendix perforation as CRP keeps going up. So they sent evidence for a contrast CT examination, which also reviewed a normal appendix and suggested right pyelonephritis. So this is the image of the appendix. So here we can see skin. So if you look at the top left corner of your screen, there's skin, subcutaneous layer, so superficial subcutaneous layer, deep subcutaneous layer. Then we have the anterior abdominal wall muscle, and then from here you can then start having the peritoneum and the bowel. So this here is the appendix here. So it's a bit subtle, but it can, when normal, it can be that subtle and it can be that tricky to see. Some literature say about 50% of normal appendix are not visualized on ultrasound. In many cases, it can be a bit tricky to see a normal appendix, but it doesn't mean we shouldn't try, because when we do, when we confidently visualize the appendix, then we can say, yes, this patient does not have appendicitis, and the doctor can focus on trying to find what the actual cause of the patient's concern is. So to the right side of the screen here, to the right side of the screen here, we have a transverse view of the same normal appendix, measuring 4 millimeters there, and then I just sketched out a schema around the appendix there to help you see better. And just here you can see the appendix there. So that's the normal appendix. Everything else was normal as far as ultrasound is concerned on this patient. So this is a second case of a 35-year-old female who presented with 1 week history of right iliac fossa pain and nausea. And we can see that she had a normal appendix here. We can see a bit of the normal bowel, most likely the cecum there. And just here, we can see the normal appendix again here. So that's the normal appendix there. And the same patient can see normal bowel loop, and then the normal appendix there, blind ending, tubular, non-peristaltic, but compressible loop of bowel. So here we have the terminal ileum. So you can see it opening into the distal ileum there, or opening from this, continuing from the distal ileum there and opening into the cecum. Here you can see a bit of, gas become materials, chine in the, become chine in the distal end of the terminal ileum going into the ileocecal valve. We couldn't image the ileocecal valve here. So this is the terminal ileum there. And you can see the wall stratification, the individual layer of the bowel there. And you can see the caliper placement of the measurements there. So we tend to shorten terminal ileum as CI. So case 3, a 7-year-old female presented with ongoing intermittent abdominal pain and bouts of vomiting, reduced appetite, lethargy, nausea, and weight loss. However, our blood results was normal. So this was a pediatric case. And here we can see the appendix there. Yeah, sometimes when normal, it can be that subtle. But like I said earlier, it's quite nice to be able to see it and image it confidently, because that helps prevent any further investigation, like carrying out a CT scan on a 7-year-old. If we can answer the question with ultrasound, then there's no point exposing our patients to radiation. So here again, we can see the appendix, the normal appendix there, just there. And then over here, we can see it just here. And you can see the iliopsoas muscles there. You can see the iliac vessels here. So let's see the iliopsoas muscles here. You can see the appendix medial to it there. Well, in this case, it appears more anterior, but it's more of medial. So case 4. A 21-year-old female presented with 1-day history of pain radiating to the right iliac fossa with associated nausea. Ultrasound revealed a normal appendix in the right iliac fossa and a 32-millimeter hemorrhagic cyst in the right ovary. Ultrasound done, then so patient had another ultrasound in 8 months' time for some other reasons, and ultrasound of the pelvis and the hemorrhagic cyst had resolved. So 21-year-old patient with right iliac fossa pain, but our appendix was normal. So it most likely would have been the pain would have most likely be coming from the hemorrhagic cyst in the right ovary. This was a transvaginal examination. And here we have the normal appendix there. And also here you can see the iliac vessels here. So the normal appendix just goes around there. You can see that. So that's normal appendix, and that's the right ovary with the hemorrhagic cyst within it. And the 5th case, a 28-year-old female presented with tender right iliac fossa and suprapubic, tender right iliac fossa and pain in the suprapubic region. The WCC and CRP were normal. Patient was sent for ultrasound querying appendicitis. However, ultrasound revealed a normal appendix in the right iliac fossa and a complex complex ovarian cyst on transvaginal ultrasound. Patient did not have a TV scan. Complex ovarian cyst on transabdominal ultrasound. Patient did not have a TV scan. It was declined. But the patient had a scan again in 5 months' time, and the hemorrhagic cyst had resolved on another CA scan. So this was the appendix here, and you can see in color Doppler, we can see just some artifactual Doppler signals. They are not real. That's the appendix there. So here we can see an example of wrong caliper placement measuring the appendix. So during the actual scan, the appendix was measured wrongly, but then after the scan, we used PACS and we're able to use the measurement function on PACS to put the caliper in the right place and get the proper measurement there. So that's a normal appendix here. Now, case 6. A 29-year-old female was admitted with 1-day history of right iliac fossa pain, nausea, vomiting, and tenderness. Blood tests revealed slightly raised WCC. Ultrasound of the abdomen and pelvis was performed and revealed a normal appendix. The cause for patient's symptoms was not found on ultrasound. So here we can see a long appendix there, all the way there. And you can see the iliac vessel. You can see here that there's evidence of compression because the iliac vein, external iliac vein here was compressed here. So you can see the appendix there, the artery is not compressed. But over here, when the pressure was relieved a bit, you can see the appendix here. You can see the vein is back open. So yeah, so that's a normal appendix, and you can see it better here. On the seventh case, 29-year-old female presented with one-day history of progressive pain, vomiting, and nausea and dizziness. The blood inflammatory markers were all elevated, including amylase. Our ultrasound was requested with query appendicitis. The ultrasound revealed a normal appendix measuring 6 millimeters and gynecological causes for patient's symptoms. The patient was in a lot of pain when I examined her. And you could see the ultrasound, the appendix on ultrasound was normal. Very beautiful appendix, actually. You can see the individual wall layering, and you can see that that's all normal. And the entire appendix itself measured 6 millimeters in AP caliber. There you can see a normal bowel loop there, and on transverse view you can see the appendix nice and beautifully there. And then the patient had a TV scan which revealed this in the 2 ovaries actually. So patients did not have any further imaging and went on to have an emergency intervention for this, because she was in a lot of pain. So appendicitis. Appendicitis is the inflammation of the appendix when it's more than 6 millimeters in AP caliber. It's often triggered by luminal obstruction, lymphoid hyperplasia, and some other rare causes like Crohn's appendicitis, etc. The most common reason, appendicitis is the most common reason for emergency operation in the Western world. And the usual treatment is surgery, usually laparoscopic appendectomy. Sometimes they carry out open laparoscopy when things have gotten a bit out of hand. For instance, in a situation of significant peritonitis, abscess, and things like that. We try to catch it early before it gets that out of hand. And appendicitis mostly affects children and young adults. The clinical presentation of appendicitis usually includes a combination of an acute onset of pain in the periumbilicus, right iliac fossa, sometimes start around the umbilicus and then migrates towards the right iliac fossa. You also tend to have nausea, vomiting. Then when blood examination is carried out, you tend to have elevated CRP, elevated WCC, neutrophils, and things like that. So a combination of one or all of 2 of those would normally, especially with a right iliac fossa pain, would most likely put the clinician's mind towards the possibility of appendicitis. And then in our trust with such combination, patients are referred to ultrasound, to have a full abdomen and pelvis ultrasound, and then a focus on the bowel, to be more focused on the appendix. And then if the CRP and WCC are raised, or if one of the 2 is raised, and you don't find the appendix on ultrasound, then patient goes ahead to have a CT scan to confirm that patient doesn't have appendicitis. But if you can find a normal appendix on ultrasound, the patient doesn't need to have a CT scan. It's just always appreciated if you can confidently find it. You don't want to make things up and misguide the clinician. So clinically, appendicitis can be categorized as uncomplicated or complicated appendicitis. We can also see the signs, the evidence of this, and we can differentiate these on ultrasound usually. Uncomplicated appendicitis is an inflamed appendix with no secondary features. Usually, is the most commonly encountered appendicitis we see on ultrasound, where the appendix, some people call it wall appendicitis. So the wall of the appendix gets inflamed, and that's it. That's all. No obstruction or anything like that. No abscess, no calculus or anything like that. And it has been reported to be successfully managed with antibiotic therapy. So most of these patients can possibly have antibiotics and go on to live their normal life. However, there are a few literature I encountered recently about follow-ups on patients who have had antibiotic therapy for uncomplicated appendicitis. A number of them do possibly tend to come back with a reoccurrence in about a year or so afterwards. But a good number still don't have to, come back for it. So it puts the surgeons in a dilemma whether to, continue carrying out antibiotic therapy if it's worth it, or, just take out every inflamed appendix as soon as it's inflamed to avoid reoccurrence. But that's something the surgeons are concerned about. So if we look at this case number eight for today, so it's a 19-year-old female patient who presented to the gynecology assessment unit in our trust with a 6-day history of worsening abdominal pain, intense pain, actually 10/10, and some left iliac fossa tenderness. Ultrasound was done. So the gynecologist requested an ultrasound to rule out ovarian torsion. When ultrasound was carried out, patient had an inflamed appendix adjacent to normal ovary. So here we have a few images here. So here we have an image of the right iliac fossa using a linear transducer. You can see the frequency here, 9 megahertz linear transducer. Reviews the inflamed appendix there, and we have mesenteric fat edema wrapped around the appendix. You can see the echogenic mesenteric fat there. That's mesenteric fat edema. And then here we have the transverse view of the inflamed appendix with the mesenteric fat there. Still the same linear transducer. They're all linear transducer images. And here we have the measurement of the appendix there. I can't remember what it measured. But yeah, it was inflamed. There. And then here we have TI, terminal ileum. So you can see a normal terminal ileum. The terminal ileum is never blind ending because it continues from the distal ileum and opens into the cecum. So it's so you can see the terminal ileum here, and then here we have the left iliac fossa with normal bowel loop. There was nothing indicating pain in the left iliac fossa on ultrasound. And here again we have down into the pelvis. Now we have, because it was quite slim, we could use the 9 megahertz frequency linear transducer to image the pelvis. It was a beautiful image of the ovaries with normal follicles there. I can see the appendix just next to the ovary there, which might have explained why the gynecologist would have anticipated a gynecological abnormality. But the ovary looked normal in ultrasound. So this is a case that also highlights the use of ultrasound in examining the appendix and the bowel. So the case number 9 now, a 25-year-old female was admitted with right iliac fossa pain and abdominal tenderness. CRP was slightly raised, WCC was normal. Transabdominal ultrasound reviewed some reactive lymph nodes in a significantly tender right iliac fossa. So the right iliac fossa was very, very tender, but we didn't see anything on the right iliac fossa while scanning transabdominally. We could only see some reactive lymph nodes and maybe a bit of mesenteric edema, but nothing untoward. So then we went ahead to do a transvaginal ultrasound, but couldn't see much of the ovaries from the transabdominal view. So transvaginal TV reviewed a 7 millimeter inflamed and tender appendix in the right adnexa, which was confirmed on laparoscopic appendectomy. So here we have the transabdominal view. You can see a bit of dullness around this right iliac fossa. You can't really see much going on. And then we could see the reactive lymph node there. That's the iliac vessels there. And then we did a transvaginal ultrasound, which reviewed hypervascularity, an hyperemic bowel loop there, blind ending, tubular, non-compressible. And during sonopalpation, the patient told me, it was tender. She felt most of her tenderness there. You can see it's medial to the right ovary there. You can see the structure there. That's the appendix. Here is an adjacent loop of bowel, probably the cecum. Just more of a solidarity thickening reaction. but it wasn't inflamed. It just appeared a bit prominent, the wall. And there you can see the appendix there. And you can see it's just here as well. So transvaginal ultrasound can help to confirm a pelvic bowel pathology, pelvic appendicitis and things like that. And also now we are all aware that the appendix can be a bit low lying into the pelvis. So it's always important to have a general view when looking at these structures. So case 10, a 47-year-old male, this time male, was referred to ultrasound with a day history of right-sided abdominal pain with nausea, but no fever. So while WCC was raised, CRP was raised, and the doctors queried appendicitis. Ultrasound revealed 9mm inflamed appendix in the right iliac fossa, adjacent mesenteric edema, and some free fluid, and also mild fecal wall thickening. So this was a case of a 47-year-old male, and you can see the appendix inflamed here in the right iliac fossa, mesenteric edema all around it there, and you can see the thickening of the cecum there in the right iliac fossa. So features were consistent with appendicitis, uncomplicated appendicitis. So case 11, a 36-year-old female was presented with a 4-day history of right lower quadrant pain, nausea, and she was unable to walk due to the pain. WCC was slightly raised, neutrophils were normal. Ultrasound revealed an inflamed appendix, which measured 7mm in AP caliber. So we can see the appendix here. This actually is a nice view of the appendix because we can see the individual walls there. So if we just have a little recap, I'd say the serosa layer, the muscularis propria, hypoechoic muscularis propria, then the hypoechoic submucosa, the hypoechoic mucosa, and then the hypoechoic mucosa interface, which is also where the lumen is. And that's the same here. You can see the appendix there. And then you can see the terminal ileum there. You can see where it's continuing from the distal ileum there, and then it continues into the cecum there and there. So you can see that that's a normal terminal ileum, but a marginally inflamed appendix. A normal appendix is 6mm and below, and this was 7mm. So yes, it is inflamed, but not complicated. Case number 12. A 35-year-old female presented with 1-day history of right upper quadrant pain. She feels sick, feverish, and had raised inflammatory markers. The patient was known to have cholelithiasis for 5 years now, and she's had previous pain in the past. She's had ultrasound that confirmed gallstones and pain. So this time around, she presented with some acute pain in the right upper quadrant, and the doctors were suggesting an ultrasound to check for complications from the gallstones. So this scan was done by one of my colleagues who I was training on that day and this very afternoon. So she scanned this patient and checked the gallstones. To scan for the gallbladder. We could see the gallstones. They didn't look like they were causing any acute problems, and you can see basically the gallbladder with gallstone and the common bowel duct there. You can see the gallstone there. So at the end of the scan, the patient mentioned, so we asked the patient, so where exactly is the pain? And then she said, you know what, it's down here, not up here. I don't know why the doctor actually had to check up here, but the pain is actually down here, this new pain. So I took the transducer and then had a look, and lo and behold, we found this. So the appendix was in the right iliac fossa. We can see the mesenteric fat edema. You can see inflamed, non-compressible tubular blinding in the appendix in the right iliac fossa. It measured, I can't remember what it measured, but it was inflamed. It was above 6, definitely above 6, about 7 or 8 millimeters. It was inflamed. So we concluded that it was a case of appendicitis, active appendicitis. So this was a 36-year-old male who presented with right lower quadrant pain, which was worsening over time. The patient had high CRP and high WCC, and was sent to ultrasound pre-appendicitis. Ultrasound reviewed an inflamed appendix measuring over 13 millimeters in AP caliber, and some mesenteric edema and free fluid. Seminal ileum was normal. You can see the appendix here. So that's an inflamed appendix. So inflamed appendix. Here you can see there's lots of wall stratification there. You can see on transverse view that's the appendix, slight, edema around fluid seeping through around there. You can see increased vascularity around on the submucosa of the appendix there, and then you can see normal terminal ileum down here. So it was the case of appendicitis. So case 14, a 30-year-old male presented with one-day history of right iliac fossa pain radiating to the umbilicus. Patient had nausea and tender right iliac fossa. CRP was raised, WCC was normal. Ultrasound reviewed an inflamed appendix measuring 10 millimeters in AP caliber adjacent and there was adjacent mesenteric edema and some reactive lymph nodes in the right iliac fossa. So in this case, the interesting part about this case is that the base of the appendix was normal. So this case highlights the importance of imaging the entire appendix, trying to make sure you see it all the way to the tip, the fundus, the distal tip of the appendix. But the base was normal, but then as you get towards the body, it starts getting increased in AP caliber up to the fundus. So when I took the measurement here, the base was 4 millimeters, absolutely normal, and then the body was about 7 millimeters, which is abnormal, and then the fundus was 10 millimeters. So it's a case of appendicitis. You can see increased vascularity there, hypervascularity, and on transverse view, you can see the increased vascularity leading to the appendicular artery, and then you can see it on B-flow imaging as well, where it lights up there. So that's appendicitis. So it's quite important to lay emphasis on the significance of imaging the entire appendix if you can, where possible, because that, especially when it seems normal from the base, don't just stop there. Please try to have a good look and make sure you see the entire blind ending tubular structure of the bowel with no peristalsis and no compressibility. It's normal. So case 15, a 42-year-old female presented with a 5-day history of constant lower abdominal pain. The pain was worse on movement. Blood results were pending at the time of ultrasound. So the patient was sent for an ultrasound, but the blood result had not arrived yet. So they wanted us to rule out an ovarian cyst that might have been causing the pain. So we performed an ultrasound, and there was a 7 millimeter inflamed appendix seen in the right iliac fossa, which was right at the site of patient concern. So we asked the patient, where is the pain? Here. Place the probe there, and we saw this. So, and this was done after we had scanned everything else, the liver, kidneys, gallbladder, ovaries, and everything else. So this is the appendix there, and it measured 7 millimeters. It was non-compressible, blind ending tubular. On transverse, you get like a target appearance, and you can see it there. So the clinicians got the results and thought, oh, well, these patient symptoms are not typical of appendicitis. We don't think this patient has appendicitis. Now that the blood results are back, WCC is normal, CRP is a bit raised, but we don't think it's appendicitis. So we're going to send it ready for a CT scan, which they did. Send it ready for a CT scan because they said the symptoms were beginning to improve and they were not typical of appendicitis. So CT reviewed a mildly dilated retrocecal appendix with periappendiceal stranding, which is a mesenteric edema suggestive of inflammation. So Titi basically reviewed what we had seen on ultrasound: mildly dilated appendix with mesenteric edema. Edema, yeah, it's not that prominent, but it's there. So case 16. A 27-year-old male presented with 1-day history of abdominal pain and significant right iliac fossa tenderness. The patient was generally unwell, and the patient managed with antibiotics. WCC was raised, but CRP was normal, and the patient was sent to ultrasound query appendicitis. So ultrasound reviewed an inflamed appendix in the right iliac fossa measuring 8 millimeters in AP caliber, which corresponds to the area of tenderness. So this was ultrasound here. The cecum up here, top left, here appeared normal. So that's a normal cecum. There, normal wall thickness. You can see gas in the lumen. Nothing exciting there. You can see the terminal ileum also appeared normal. The ileocecal valve is somewhere here. So that opens into the cecum, and then this continues from the distal ileum. You can see the bowel luminal gas there in the normal terminal ileum. Now in the right iliac fossa, you can see the appendix. The blind ending tubular non-compressible structure measuring about 6 mm. You can see that, and it doesn't necessarily show hypervascularity on color Doppler. Sometimes some do, some don't. But the key feature in diagnosing appendicitis is, blind ending tubular measuring about 6 mm in AP caliber, and usually corresponds to the site of patient pain. Sometimes you get mesenteric fast edema, sometimes you don't. And sometimes you get increased color Doppler signal, sometimes you don't. So transverse view of the appendix there, using a curvilinear probe before the linear, described when I talked about the technique, 6 megahertz probe, you can see the appendix there inflamed. Now that kind of gives us an idea that the appendix is inflamed. However, when you compare that to this, the difference is, is massive in terms of looking at the wall of the appendix, checking the lumen and things like that. You get more information using the linear transducer of 9 megahertz than the 6 megahertz. But this gives you a global view, global understanding of what's going on in that region. So case 17, this is a 22-year-old female who presented with an increasing right iliac fossa pain for 3 days. WCC was 17, and the doctors were querying appendicitis. So I reviewed an inflamed appendix in the right iliac fossa measuring 10 millimeters in AP caliber, and this was consistent with appendicitis. So we can see the ultrasound appearance of the inflamed appendix in this patient here. So that's the appendix, same appendix there. You can see the iliopsoas muscles there. You can see the appendix just, and then now there was compression already applied, graded compression. So this brings the appendix up to view. And here, so you can see the appendix, you can see the iliac vein, iliac vessels, vein was collapsed due to compression. You can see a normal bowel loop there. And even color, you can see the appendix is inflamed, but not hypervascular, not showing color Doppler signals. And you can see the iliac vessels there. So case 18 is a case of a 21-year-old female who presented with a day history of right iliac fossa pain, nausea, and blood results was pending. So ultrasound was carried out, query appendicitis, to rule out, or ultrasound reported to rule out appendicitis or ovarian cyst causing patient's symptoms. Now, when ultrasound carried out, it reviewed an 11 millimeter inflamed appendix in the right iliac fossa with increased wall vascularity, and there was adjacent mesenteric edema and some free fluid in the right iliac fossa. So over here, we can see the inflamed appendix with some mesenteric edema. You can see the mesenteric edema wrapping around the appendix there. In some cases, when the appendix is a bit curved, you can get sort of like, it appears like two transverse views of the appendix, but that's just the angle of insonation. So when you follow it down, you simply follow the entire track, the entire roots of the appendix along it. So you can see it there. You can see the edema and some free fluid there. You can see the appendix there and some edema around it. And you can see it's hypervascular there. And the terminal ileum just here, just there. You see terminal ileum there, that's normal. And the appendix, yeah, so this was a twin view of color Doppler and 2D grayscale. So you see the hypervascularity, and you see the appendix there. So for the 21-year-old female, it's appendicitis. So case 19. Another 21-year-old female with a day history of abdominal pain and nausea with guarding symptoms. So you couldn't really touch the region of pain because patient was really was in a lot of pain, and so she was guarding the pain. Ultrasound of the abdomen and pelvis was requested to rule out ovarian pathology. So during the ultrasound examination, the sonographer asked the patient, point out the site of pain, and that corresponds to a 7 millimeter hypervascular appendix. So you can see here that's a normal loop of bowel, and you can see the appendix down here, just all the way here like that. So that's the inflamed appendix there. On transverse view, you can see the appendix there. You can see edema around the mesenteric edema in the mesenteric part, the transverse appendix there. And over here, you can see vascularity of the inflamed appendix there. And you can see when the patient had a CV scan, there was some free fluid in the pouch of Douglas, posterior to the retroverted uterus there. So the patient had appendicitis. So that's about it for the uncomplicated appendicitis. So with complicated appendicitis, you have inflamed appendix with some other secondary features like the presence of periappendiceal collection, free fluid in the iliac fossa, appendicolis, and evidence of appendix perforation. You can find abscesses and etc. And usually the treatment of complicated appendicitis would warrant appendectomy, or at least, or sometimes open laparotomy, like I mentioned earlier, depending on the features I was saying. So this is a case of a 50-year-old male who presented with 5-day history of central to right lower abdominal pain, nausea, reduced appetite. Patient was clinically tender in the right iliac fossa, showing guarding symptoms. WCC was raised. CRP wasn't available at the time of ultrasound, and the doctor wanted to know if the patient had appendicitis. So ultrasound reviewed a 14 millimeter inflamed appendix in the right iliac fossa with an appendicolis at the base of the appendix and significant mesenteric edema and an area of likely hemorrhagic collection adjacent the base of the appendix. So in the right iliac fossa, you can see the collection there. So this is the base of the appendix there. You can see and a bright structure there, which most likely represents an appendicolis. Then you can see the shadowing, posterior acoustic shadowing. So it's there. And here you can see a normal bowel loop there. And then the collection just here. Here you can see the collection better. The appendicolis there. Transverse view of the appendix. And here you can see the base of the appendix there. That's the appendix. And you can see the appendicolis and posterior acoustic shadowing. And same here, the collection, and then the base of the appendix, and the same here. So this was a case of complicated appendicitis because patient would have had to have surgery. They won't mostly recover from antibiotic therapy. Even if they do, there's always an increased chance of imminent recurrence, especially with the presence of an appendicolis in there, because that's most likely causing a mechanical obstruction of the appendix, which irritates the wall, leading to inflammation. So it's another case. A 21-year-old female presented with 2-day abdominal pain with some vomiting, right iliac fossa tenderness. WCC was raised, CLT was raised, everyone queried appendicitis. Ultrasound was requested to rule out appendicitis. And this revealed a 15mm thickened bowel loop extending into the right adnexa. There was a small appendicolis and adjacent mesenteric edema. So this was a case that wasn't so conclusive on ultrasound when it was performed. So we, using curvilinear probe, we were able to see, that's the bladder, urinary bladder. We were able to see the appendix diving towards the pelvis there. We saw it, well, at the time, we saw it as an abnormal loop of bowel in the right iliac fossa, but really, what else could it be? It could be, I mean, it looks a lot like the appendix, but at the time, it was an abnormal bowel loop in the right iliac fossa, measuring up to 15mm in AP caliber. And over here, just here, you can see the appendicolis and posterior acoustic shadowing. And then you can see it's a bit hypervascular on power Doppler imaging. So the same patient was then referred to CT for a definite diagnosis. In our trust, the surgeons don't like when we don't give a definite diagnosis because they want to know, is it an appendicitis or not? If it's an appendicitis, then the patient goes to a laparoscopic appendectomy and has it removed. If it's not, the appendix is confirmed to not be inflamed, then the patient gets some other kind of required necessary management. So patient went to have CT scan, and CT reviewed, same day, CT reviewed 14mm inflamed appendix in the right hemipelvis with a 10mm appendicolis, free fluid, hair pockets, and some vascular congestion, and an inflammatory stranding extending into the pelvis. So this patient would have benefited a lot from transvaginal ultrasound after the transvaginal ultrasound was done, because we could have most likely would have been able to see the end of the appendix, the fundal part of the appendix in the pelvis to confirm like an inflamed appendix, and they wouldn't have needed to have the CT scan. However, the CT scan was done and then had appendectomy almost immediately. And 12 days after appendectomy, the patient had some post-op collection, so they had to be sent for another CT scan. And then afterwards, 8 weeks later, they had another CT scan, which revealed that the post-op collection and complication had all resolved. So, yeah, so the case 22. A 12-year-old male presented with abdominal pain, raised inflammatory marker, tender abdomen, fever, and was generally unwell. So this was a pediatric patient who was wheeled in, in a trolley. Patient was just laying there, was in so much pain. Was very unwell. I think it was a Saturday afternoon. The parents were worried. So yeah, we did an ultrasound on this patient, and we reviewed that the patient had a 10mm inflamed appendix with some echogenic flex within the wall. A heterogeneous collection was seen adjacent the base of the appendix with some edema surrounding the surrounding mesentery. Patient had emergency laparoscopic appendectomy, which revealed that the structure we found was a gangrenous appendicitis. So these were the images of the patient, the images acquired from patient ultrasound. So it's 12-year-old patient. That's the collection in the right iliac fossa. You see the collection there. And then you can see the inflamed appendix. This was a curvilinear probe. And then when we used the linear probe, we got that as well. You can see that obviously a 12-year-old boy. So it's a very small anterior posterior body thickness. So you can see the appendix just very close to the skin there. And then using the linear transducer, you can see that with increased mesenteric fat edema, transverse view, and you can see the echogenic flex within the interstitial layer of the appendix, within the wall of the appendix. And you can see here the collection just adjacent the base of the appendix. So I think we should maybe take a 5 minutes break, and then we can come back to continue continue on the rest of the presentation. So if we just maybe take a little break. Okay, hello again, everybody. I hope we were able to use our breaks to do the bits and bobs, and maybe had a cup of tea or something. I just had some water and rested a bit. So yeah, so we can continue now. So far we've covered bowel anatomy. We've talked about the perils and pitfalls of bowel ultrasound. We've also discussed on techniques involved, tips and tricks, techniques involved in scanning the bowel. I mean, definitely these things are easier to understand when we are shown. However, I believe, on knowing how other people do these examinations can be quite important. I've been to, like I said earlier, I've been to some conferences where a number of, prominent gastroenterologists attended, guys and women who have written textbooks and lots of papers in bowel ultrasound, and they explained how they carry out their bowel ultrasound, and it's pretty much similar to what I've explained to you. So I can assure you that if we do it the way we've discussed today, I think would mostly be on the right track. So we can go on now to just a highlight, an overview of the other pathologies, some other pathologies that we commonly find in the bowel. So the next quite common pathology we find is inflammatory bowel disease, which includes Crohn's disease and ulcerative colitis. And these are the pathologies that this is the aspect that we'll be talking on in the next 15 minutes or so. And that's going to conclude today's presentation. However, we can, depending on what the feedback is from you guys and discussion with the kind organizers, we can have a part 2 of this study, of this presentation, where it would fully talk more in details of on IBD and also diverticulitis, colitis, intussusception, small bowel obstruction. I talked about small bowel obstruction a bit today, but yeah, we can talk about in detail paralytic ileus, toxic megacolon, and some bowel malignancies. So that would be dependent on our discussions after today's presentation. But these are some of the other commonly found bowel pathologies that we can confidently diagnose on ultrasound. So IBD is made up of Crohn's disease and ulcerative colitis. Now, Crohn's disease. So bowel wall thickening is the single most important ultrasound parameter in the diagnosis of Crohn's disease. There are numerous publications and researches on Crohn's disease in particular, and ulcerative colitis as well. And the common consensus, the agreed consensus, is bowel wall thickness, and in some cases, color Doppler are the two key factors that we use in diagnosing and monitoring Crohn's disease. So In Crohn's disease, both the small and or the large bowel can be affected. And also it can affect different segments of the bowel. So it's called skipped lesions because you tend to have bowel thickening, no bowel thickening, bowel thickening, no bowel thickening. So it tends to be a bit skipped when it's a case of chronic disease. And it's commonly found, and you commonly have loss of gut signature. You tend to have mesenteric edema, mesenteric fat wrapping around the abnormal bowel. You tend to have increased disease, and you can have disease activities increased which can be similar to symptoms of appendicitis. So in a nutshell, the symptoms of an active Crohn's disease can mimic that of appendicitis. So you can have case patients that will be sent to you saying query with a request saying query appendicitis, but when you examine properly, you find out that it's not an appendicitis, it's Crohn's disease. So Crohn's appendicitis is also a possibility, but it's very rare, but it's possible. So the disease activities of Crohn's disease has been associated with increased flow in the mesenteric vessels and portal veins. So this is a bit of vascular aspect now, but these measurements are, so you tend to have increased PSV, peak systolic velocity and resistivity index in the mesenteric vessels and in the portal vein. In some research, but the measurements are not specific and you cannot easily reproduce them because for physiological reasons, some patients after having certain meal or things like that, they could have increased PSVs or reduced PSV in their portal vein. And, and also even the same sonographer or radiologist could scan the same patient a couple of times and you get different readings. So in the observer variability, if you use a GE equipment here and this person uses a Canon equipment, you might get different readings as well. So that particular factor isn't popular and not well advised, but it's worth knowing that you can play around that sometimes around checking the mesenteric vessels and the portal vein to monitor activities of Crohn's disease. So also color of power Doppler can be used to check for vascularity in the small bowel. However, this is semi-quantitative and can be quite subjective, and also machine variability matters or it comes into play, but it's quite useful and it's reproducible. So it's important to check use your color power Doppler to check for vascularity. If you have other fancy features on your machine like microvascular imaging or B-flow, you can use that as well to check for vascularity. However, the hallmark of checking for vascularity in Crohn's disease is the use of contrast enhanced ultrasound, and that's beginning to get a lot of global recognition and attention nowadays with advanced practice ultrasound. The use of contrast enhanced ultrasound, as we know, it doesn't utilize radiation. It's readily acceptable by patients, and you tend to increase and detect lower wall vascularity, and that's quite key when monitoring the disease. Also very useful in differentiating between fibrotic stenosis from inflammatory stenosis as a complication of Crohn's disease, because those two are managed differently. Fibrotic stenosis is managed, can be managed with surgery, while inflammatory stenosis will be managed with an alternative treatment when examining the activity of Crohn's disease. So contrast enhanced ultrasound is very useful in checking vascularity and monitoring Crohn's disease. So the other possible associated findings with Crohn's disease are you can find enlarged lymph nodes. Like I said earlier, you can find mesenteric fat hypertrophy, and you can find free fluid around the abdomen, in the abdomen, and some complication of Crohn's disease are stenosis, that's narrowing of the bowel, lumen, which can lead to dilatation, prostenotic dilatation, and poststenotic dilatation. And you can find intestinal fistulae, abdominal abscesses, etc. Also remember, bear in mind that the use of elastography, shear wave elastography, is also very, very useful in monitoring these activities in Crohn's disease, because that helps you check for level of fibrosis in the bowel, the thickened bowel wall. So let's look at this case. This was a 38-year-old female that presented with 4 weeks history of lower abdominal pain. Clinically, the left iliac fossa and the right iliac fossa were tender. WCC was normal, but the CRP was raised. Now, ultrasound, patient was sent to ultrasound basically to check for appendicitis. So ultrasound revealed an abnormally thickened, non-compressible loop of bowel extending from the right iliac fossa, central abdomen, left iliac fossa, and there was significant tenderness observed along the tract of this this thickened bowel, abnormally thickened bowel. However, the appendix was not visualized on ultrasound. So, like I said earlier in our trust, if you don't find the appendix, you tend to send evidence for CT just to make sure it's not appendicitis, which is understandable. So this was the ultrasound image. Our ultrasound images. If you notice here, we use one of our older machines there. So we use a 4 megahertz curvilinear transducer, and that gave us beautiful images of this bowel loop. And you can see here, it was increased to 5 megahertz here, and you can see the difference. So this here gives more detail of the wall. So you can see the submucosa of this bowel loop here appearing very thickened. There you can see it here, and everything was about 17 millimeters in AP caliber. That's a lot. The individual bowel wall was probably around what, maybe 8.5 millimeters in AP caliber. So that's way off. And that was the small bowel, by the way. So I think it involved the terminal ileum, because they extended from the right iliac fossa into the left iliac fossa and then skipped along. So you can see from the right iliac fossa there, you can see the right iliac vessels there, and then you can see the bowel wall. So with 12, a scale of 12 on the color Doppler scale, we couldn't get any vascular reading there. But however, if we had used maybe contrast enhanced ultrasound or a fancy feature on the newer equipment like microvascular imaging, we might have been able to detect vascularity, possibly. So when we switched to linear transducer using a 9 megahertz, we couldn't really get much information that we don't already know. We didn't get anything we don't already know. You can see that there. So if I go back to the previous slide, you'd see the bowel wall. They're using a 5 megahertz. So this is a clear example of the importance of the use of both transducers, curvilinear and linear. Neither of them is useless. We need to use both of them when it comes to bowel and ultrasound examinations. So you can see the image there. So the same patient, remember it was a 38-year-old female with 4 weeks history of lower abdominal pain and raised CRP, normal WCC. So ultrasound, like I said, reviewed that, the thickened bowel loop there. So the same patient was sent for a contrast CT examination later on the same day. This revealed an abnormal thickening of the long segment of the terminal ileum with inflammatory evidence. The cecum and ascending colon showed some evidence of inflammation around it. And there were multiple reactive lymph nodes around, and there was a normal retrocecal appendix stain, transverse colon, descending colon, and part of the sigmoid colon, where they all showed slight evidence of inflammation, but nothing significant. So MRI was done later that day. So that was basically thickening of a long segment of the terminal ileum. So MRI was done later that week, 10 weeks later, which showed a 15 to 20 centimeter segment of variable wall thickening of the distal ileum to the ileocecal valve with absent peristalsis, marked inflammation of the sigmoid colon, And that was pretty much it. And the conclusion was active Crohn's disease. So if we go back to ultrasound, you can see, so this thickened loop of bowel did not reveal any peristalsis within it. There was no complication. There was no luminal narrowing or stenosis or evidence of stenosis around. So that was a case of active Crohn's disease. So these were the CT images here. Some CT images, transverse view, coronal segment there, and the sagittal segment here of the bowel. And these were the MRI images of the same patient, the one that was done 10 weeks later. So then, so that was active Crohn's disease. So we'll move on to the next slide. So ulcerative colitis. Now, ulcerative colitis is also the second part of inflammatory bowel disease. So ulcerative colitis, unlike Crohn's, involves the mucosa of the colon. Remember the layers, 5 layers of the bowel. Serosa, muscularis propria, submucosa, mucosa, and mucosal interface. So hyper, hyperechoic layers of the bowel. So the ulcerative colitis involves mucosa of the colon, and it travels in a retrograde fashion from the rectum down to the rest of the colon. Just a point to highlight on Crohn's. So Crohn's disease can occur anywhere along the bowel, from the anus all the way up to anywhere within the bowel, all the way up to the esophagus and beyond. So, but ulcerative colitis extends from the rectum, the region of rectum, in a retrograde fashion, sigmoid colon, descending colon, transverse colon, ascending colon, and it mostly only involves the large bowel. It rarely involves the small bowel. The typical feature is increased wall thickness of the colon, which we see on ultrasound. The gut signature can either be preserved or lost. In Crohn's disease, the gut signature is usually mostly always lost. And in active inflammation, you tend to have increased wall vascularity with thickened wall. Usually you shouldn't have an increase. You shouldn't even really have much vascularity in the wall of the bowel, of the large bowel in particular. But in an active inflammation, you have increased wall vascularity and a thickened wall. So in a way, the bowel ultrasound helps us differentiate between Crohn's disease and ulcerative colitis by checking the location of the disease. So with Crohn's, you tend to mostly have it in the terminal ileum, and you can have skipped lesions and things like that. Ulcerative colitis hardly ever involves the small bowel. However, it travels in a retrograde fashion from the rectum, sigmoid colon, descending colon, transverse colon, like that. So, so the location of the disease would help you determine which of the two it is on ultrasound. And also, in ulcerative colitis, it tends to have more mucosa. It tends to affect the mucosa layer of the large bowel. Unlike ulcerative colitis, you don't really necessarily tend to. So you tend to have highly, increased thickness in ulcerative colitis because it involves the large bowel. Also, you tend to have the presence of gut signature is preserved usually in ulcerative colitis, and the surrounding mesenteric fat involvement. So you don't tend to have mesenteric edema in ulcerative colitis, but it's more common in Crohn's disease. The use of contrast enhanced ultrasound would help us show wall hypervascularity, and it's used to evaluate treatment response. So it can reveal mucosa healing, evidence of mucosa healing in the bowel wall after treatment. So CUS is quite useful when it comes to monitoring IBD. Complications of ulcerative colitis are toxic megacolon and portomesenteric vein thrombosis, which can be well examined using CUS. So if we look at this case, this is a 21-year-old female who presented with 4-day history of pain in the right iliac fossa. So that's the right iliac fossa pain. Nausea, diarrhea with watery watery stool which contains blood. CRP was raised, WCC was raised, and patient was sent to ultrasound. An ultrasound request was made, query appendicitis. So on ultrasound, we found a mild thickening of the sigmoid colon, descending colon, transverse colon, and ascending colon. The transducer there was transducer tenderness observed along the sigmoid and the transverse colon. The cecum and appendix appeared normal, and ulcerative colitis was suggested on ultrasound. And patient had the CT scan 2 days later, which also suggested ulcerative colitis, and recommended stool sample and further investigation, endoscopy if need be. So this were the images obtained on ultrasound. So this is the sigmoid colon here. We can see we use the high frequency 9 MHz transducer here. So now the sigmoid colon, you can see the rugae of the colon, and that's quite thick there. You can see. So you saw the normal colon I showed you previously, and this is nowhere near it. So you can see that we've lost that fine, fine layer of colonic gas and the anterior wall of the colon, and now we can see the entire colon, the thickening, and you can see slight increased vascularity, patchy around the walls there. This is our sigmoid colon. Left lateral, which is the descending colon, you can see wall thickening here, and it's descending into the sigmoid there. And this is part of it. This is the upper descending colon there, close to the splenic flexure. There's the descending colon. And then now we get to the transverse colon. Remember I told you I scanned in a retrograde fashion on the colon. So this is the transverse colon. You can see the thickening. You can see the mucosa layer there. I think it's more prominent here. We're getting increased mucosa thickness there. And here you can see the ascending colon here, and that's the cecum. This is a normal, fine normal cecum, and you can just make out the appendix here. So that's the appendix there. You can see the iliac vessels there. This is the appendix there. And the appendix was normal, cecum was normal, ascending, transverse, descending colon, and sigmoid colon were all thickened. And CT scan confirmed that 2 days later. So this is the final case for today. So a 50-year-old male presented with 1-day history of right iliac fossa pain and nausea with guarding and very tender right iliac fossa. WCC was 14.7, and patient was sent to ultrasound, query appendicitis. So ultrasound reviewed this. So this is neither appendicitis nor appendicitis nor colitis or nor IBD. So ultrasound reviewed this. So this is the terminal ileum. It didn't really seem hypervascular. I think it was mostly bowel artifact on the Doppler artifact from the bowel. However, so I'm going to review the bulky cecum with the wall thickness of 8 millimeters of wall thickness now, and the marked increased vascularity. So there was localized free fluid, and the appendix was not well visualized on ultrasound. However, the base appeared normal, but contained a large appendicle. So I'll show you. So that's the sorry about that. So that's the terminal ileum there opening into the cecum. So here we have the base of the cecum there. You can see the base, sorry, the tip of the cecum there. You can see the base of the appendix somewhere here. We couldn't really get much of the appendix there. So you can see this appendicle there. That's a large appendicle there at the base of it. This appendix here looks normal at the base. Other than rule out appendicitis. So yeah, so we reported based on what we've seen. Large appendicle, the bigger appendix was normal, but we didn't see much of the appendix. However, the cecum was bulky. You can see here, cecum was bulky, and that's another frequent image there. You can see that. So that was okay. And you can see the fine bacteria is quite increased. It looks beautiful, but it's very painful for the patient, unfortunately. So yeah, it looks very well defined on ultrasound. You can see that there was a bit of localized free fluid adjacent to the cecum there. And when we measured the wall from the lumen to the junction between the serosa and the adjacent structure, it measured about 8 millimeters in thickness. So you can see that the patient went on to have a CT scan on the same day because we didn't convincingly see the appendix to tell the surgeon if it's a serious appendicitis or not. So we had a CT scan, and CT was reported to be difficult to interpret due to reduced intraabdominal. However, the appendix wasn't inflamed, and the findings were concurrent to ultrasound. So you can see the appendicolis there at the base of the appendix. They also found appendicolis. They didn't think the appendix was inflamed. On CT was confirmed that the cecum was also enlarged with some inflammation around it. So CT ruled out appendicitis, and found the ultrasound was very useful in this case because radiologists referred to the ultrasound in their report, saying from the images of an ultrasound, we don't think this is appendicitis. We think this is actually in line with what ultrasound said. Then it's inflamed with colitis. And we suggest you treat it with antibiotics, and if nothing changes, then carry out some stool investigation, and see what you find. So that was a case of colitis, inflamed active inflammation of the cecum. So in summary, it's not always appendicitis. As you know, we've seen cases of hemorrhagic glomerulonephritis making appendicitis. We've seen also colitis. We've seen Crohn's disease making appendicitis. It's not always appendicitis, but it's important to look carefully and check everything that needs to be checked. If you're not sure, get a second opinion, get third opinion. At the end of the day, it's a patient, it's someone's loved one, and it's our duty to give our best. So it's not always appendicitis. We also should adopt the technique that works and stick to it. So read up some ultrasound textbooks, bowel ultrasound textbooks, see how other people do their other experts their bowel ultrasound, and just follow a technique that works for you. Like I explained earlier, it's better to follow the obviously mow the lawn, as I said, important to mow the lawn, and then follow the large bowel from the signal colon all the way back. That way you'd easily rule out ulcerative colitis. First, when you get to the terminal ileum, you're easily ruling out Crohn's disease, and you can easily check the appendix in the right ciliary fossa, and then you can mow the lawn to check the rest of the small bowel. So your technique matters a lot. It also helps to invest in a good ultrasound machine. Speak to your department. If your ultrasound machine is quite old, the world is moving really fast. It's 2022. You shouldn't be stuck with some very old ultrasound machines. You need to get new ultrasound machines with many beautiful things that new ultrasound machines do these days that you just can't beat it. So it pays a lot to invest in a good new ultrasound machine. Communicate with your patient, very important. Speak to them. Oh, hi. Tell me, so what's been going on with you? So how long have you had this pain for? When did this pain start? Can you show me where this pain is? Can you point at it with one finger, please? If you're scanning kids, just play with them. Like, oh, the video game. Would you like to point at? Use my video game joystick to point at where your pain is or something like that. And they're like, oh yeah, just there. And they're like, okay, let's have a look. I look up on the screen. You check, and you find usually trying to find where the patient knows. Sometimes they tell you it's there. And in that case, you have to look everywhere around. But yeah, it pays to communicate with your patient, ask them questions, and also know your limitations, know what you know, and know what you need to know. So read up, ask questions. If you don't find it, if you're not sure, then get a second opinion. It's very important. It helps. At the end of the day, it helps the patient. Everyone is, the patient gets their diagnosis quicker, and hopefully reduce their hospital stay, they get the right intervention, and everybody, and they go home to meet their family as soon as possible. Everybody's happy. So yeah, follow up on your cases where possible. Try to find out what actually happened. What was that thing I saw? Was it really the appendix? Was it this? Was it that? What did they do? What did they see next? And that way you'll be able to improve yourself over time. And when you get feedback from your colleagues, from the surgeon or anybody, welcome it. Accept the feedback and use it to develop yourself over the next year. So here's a bonus case. It's a case of a 31-year-old male who presented with regular sapiens, fever, nausea, raised WCC, and raised CRP. They are trying to question if the question was appendicitis, appendicitis. So this was what we found on ultrasound. We found this, we found that, and we found this. So I'm not going to tell you what part of the abdomen this was. I'm not going to give you any clues. So if anyone can mention, maybe I'll probably pause the video and then ask if anyone can tell us what, can explain what they've seen on the screen. So if you look at it here, I'll just be quiet for a bit and just show you both images. If you look at it there, just tell me what you think it is, and then just read up one person, or you can put it in the comment section, and then we'll see what it might be. So so this was a case of a patient who was known to have Crohn's disease, and then presented with these symptoms. So the doctor thought, okay, well, maybe this might be appendicitis, coming up as a complication this time around. So we sent him to ultrasound, and we found this. So this patient already had a CT scan a while ago, like, I think months ago, something like that, which Crohn's was diagnosed, thickening the terminal ileum. Yeah, this corresponds to what we found here. So this was the terminal ileum. You find that some skip lesions there, and that's the bowel thickening there in the terminal ileum. There you can see lots of wall stratification. You can see a bit of luminal gas there. So that's Crohn's disease, flare up of Crohn's disease in the terminal ileum. Yeah. So we're pretty much done with the presentation. This is a case of complicated appendicitis that was recently published on the Sage BMOS ultrasound platform. For the case of a 19-year-old patient who had, presented with right pain, and we found some beautiful images of complicated appendicitis, which was confirmed on CT. Patient didn't have CT, it was confirmed on laparoscopic appendectomy and histology, macro and microscopic histology. So we wrote about it, and it was published. So I would recommend that you can have a good read of this. It's only a very short case report. Probably takes about 15 minutes to read. So you can read it when you are getting ready to sleep or taking a bathroom break or anything like that. Just have a good look. It would reinforce your understanding, your knowledge on the techniques, and also differentiate between uncomplicated and complicated appendicitis. And I hope you enjoy the read. So have a look at this and see what you think. And I always welcome feedback. You can send me an email or drop me a message on LinkedIn, which I'll probably share at the end of this presentation. So for further reading as well, have a look at this EFSUM course book, very useful. Check the GI chapter in it, that's very useful. Also check the EFSUM recommendations and clinical guidelines for intestinal ultrasound. I was in a conference recently in Timișoara, Romania, where the authors of this chapter of these guidelines presented the guidelines, and you can tell that they put in a lot of research and thought towards coming up with all these concepts that led to the guidelines. And yes, they're very useful. So have a good read on this. Yes, I think you would you'd find it very useful and it will help with your knowledge on bowel ultrasound. So these are the references, and thank you so much for listening.